Good evening, and thank you for joining us for episode 5 of season 4 of Doc Talks with Dr. Forrest, Tennant, and friends. We have a special guest tonight, and we have a lot of people that are here with us this evening. We have a full boat tonight and a very great show ahead of us. Looking forward to a lot of great surprises. So, Dr. Tennant, I think we have Dr. Ibsen here with us as well tonight. Happy that we could all get together. And we'll go ahead and turn it over to you, Doc. Thanks so much.
Okay. Thank you. I'm delighted to be here and know that our guests are here, and I hope Rhonda's here somewhere. We were planning on a couple of things to mention. Last week or two, I made a point of using the term constant pain to really let people know that's what we really mean when we use the term intractable pain. Now, let me talk about terminology for just a moment so we're very clear, because you're looking and you're right in a time, if you forget the opioid controversies and forget all this other stuff, and you go to the science that's going on, we're getting ready to change concepts, terminology, and a lot of things going forward. Now, those of us in the research community, have almost no connection anymore with universities or NIH because they don't do research anymore, not in problems like pain or in common ambulatory problems. Now, what's happened over the centuries? There's always been, thousands, millions of chronic pain patients. Most of us, if we get to be age 60 or 65, have got something that's chronic and painful. We've got a bad bunion, we've got a neuropathy, a carpal tunnel, a fasciitis, a headache, we've got something. And that's just life. But there's always been a subgroup of patients that have had different names over time. Interestingly enough, in the 1700s, the term for this subgroup of patients that had constant pain was called persistent pain. And that term has been brought back even in recent times. Other terms that have been used to describe this subgroup of pain have been things like high impact lately. Central has been used. The term today that is most used to identify the subgroup of people is neuropathic pain. Now, these terms don't have anything to do with what the real facts are. The facts are these. We really have, among chronic pain, two groups. We have intermittent periodic pain, at which, your headache comes and goes, your arthritis flares up 3 days a week, and your bunion flares up twice a month. I mean, that's chronic pain. But then you've got the constant pain. That's when it never goes away. It's 24/7, and most people watching this have chronic pain or near chronic or constant pain. That means unless you're asleep, you feel the pain. Yeah, it's there. It doesn't go away. And what's interesting is that most people know almost to the day and the month, sometimes the hour, when their pain shifted from being once in a while to constant. Okay? They know the day, the time, the event, the place. Okay. And so that's one thing. Now, the other thing about constant pain means that something in the nervous system has been damaged, doesn't work anymore, because pain comes on through electromagnetic energy in the body. And when the pain is healed, the disease gets under control, those mechanisms shut down the pain. In fact, I like that term. It's pain shut down. It stops it. Now, if you have pain that's going on for a long, long time, what this means is you've either damaged a nerve. It will no longer conduct electricity. It's gone. The common condition of that today is small fiber neuropathy, which gives you the pudendal problems, the burning mouth, the burning feet, or the pain all over, which I'm going to come back to in a couple of minutes. The other causes of constant pain are nerve entrapment. That means that the nerves are entrapped in a mass, in a fibrous mass. That mass is usually inflammatory with adhesions, and it may damage the nerve, or it may just cut off the electrical transmission. Now that's adhesive arachnoiditis. Adhesive arachnoiditis is really an entrapment of cauda equina nerves inside the spinal canal. It's a nerve entrapment disease. And then the third reason that you can get constant pain is in the brain, the systems, and you're going to hear something called the glial cell, which really has two small cells, microglia and astrocytes. You don't need to know that. But the term glial cell, you probably want to know. And you also want to know that glial cells are what cause inflammation and adhesions in the brain. And if you get glial cells that form inflammation, and that inflammation will destroy some of your neurotransmitter receptor systems. Put simply, it'll destroy some of the mechanism that shuts down pain. Now, one of the things nobody likes to talk about is we have all kinds of brain scans documenting this. We have all kinds of chemical studies documenting these things. Every once in a while I hear somebody has terrible constant pain, they can't get relief, they can't get their opioids, and somebody says it's all in your head. It's all, well, it may be in your head, but it's neuroinflammation wiping out receptors is what it's doing. And so it's not psychologic, and it's not something that you can wish away, or if you just shape up or take a little Tai Chi or go to a therapist, it's going to go away. Constant pain is a medical problem. And it takes a lot of medicine and a lot of non-medicine measures to control it. Now what I'm going to do is take you on to chapter number 2. Okay. How do you end up in the body getting constant pain? It was a mystery for a long time. It's been a mystery for centuries. I mean, Hippocrates wrote about it 4 centuries before Christ was born. So we really don't know, but we now know. Okay? Now, to get intractable pain, you have to go through a pathologic group of steps. I call it a pathologic pathway. You don't just wake up one morning with intractable pain. You start off with problems, diseases, genetic conditions, what have you, and you go through a pathologic pathway to get to having intractable pain. And certainly if you end up with a disease like adhesive arachnoiditis, you're going to have a terrible pathway. That's the end. So I want you to think of arachnoiditis in one sense. It's the bottom. That's when the pathway ends. Now, when you hit adhesive arachnoiditis, unfortunately, you're also a sitting duck for cancer and dementia, paralysis, early life, a whole bunch of things. But that's at the bottom of the pathway. The pathway starts up here. Now, let's start for just a minute on something that we've now learned. We talk in terms, and I'm going to now take you back a little bit. When I first started treating intractable pain patients, and it goes clear back to my Army military days in the late 60s and 70s, at that time, for about a 20-year period, for a generation, people with intractable pain had a lot of diabetic neuropathy, for example, a lot of sickle cell disease, cancer or post-cancer neuropathies. I remember treating a lot of people who had post-polio neuropathies. They make a big deal about long COVID. Well, we had long polio, we had long herpes, we had long everything after viruses. But everybody today has got to make a name for themselves or make a buck, one of the two. So anyway, also back in those days, we had conditions like abdominal adhesions. We had a lot of slow-growing cancers like melanomas or lymphomas that we treated. Interstitial cystitis was a terrible problem in those days. Chronic pancreatitis. What I'm getting at is that we had in those years, we would have intractable pain or constant pain and a single cause. Okay? Now I want everybody to get that. Intractable pain, one cause. Chronic pancreatitis, abdominal adhesions, post-polio neuropathy, lymphoma, one situation, one cause, intractable pain. Now, over time, what happened was we started developing treatments. By we, I mean the scientific medical community. A lot of good people contributed a lot of good research and a lot of good efforts to come up with treatments for these single conditions. And nobody talks about the successes of medicine these days because everybody knows it's a little dysfunctional and very political, very expensive. We all know those things. But what's not appreciated is that we've now got specific treatments for sickle cell disease, interstitial cystitis. We've improved treatments for diabetes, for hypercholesterolemia, chronic pancreatitis. We've got all these biologics now for everything from regional enteritis and ulcerative colitis and rheumatoid arthritis, Sjogren's disease, type 1 diabetes. So we've got a lot of treatments that may not have cured everybody, but it has brought the pain levels way down. We talk about how opioid use is way down, and they always like to say that's due to regulations or something. In reality, doctors just don't have to use as many anymore because we've got treatments for a lot of the problems that we had before. But now here's what I want to get across to you. We now have two major causes of intractable pain. Okay? Two major causes. And I'm going to have to talk to you about this. And this means that unfortunately, we're going to have to adopt some new disease labels and some new concepts. Okay? And it may sound a little complex. So get your tennis shoes on, folks. Now, first thing we're going to do, we're going to talk about something called risk factors. In the past, we used to call these causes, but they're not really the causes of the intractable pain. They're risk factors. They put you at high risk to develop adhesive arachnoiditis or constant intractable pain. Now, I'm going to talk to you about what those risk factors are. There's only a few of them. And I know I can see people right here's faces, and I know some of you have these things. First off, your connective tissue diseases, your Ehlers-Danlos syndromes, your Marfan's, what we call today spectrum disorders. And so that genetic group of collagen deficiency disease puts you at high risk to develop intractable pain, not the day you're born, but maybe 30 or 40 years later. Okay, second big thing, trauma. Now, that trauma can be to your head, can be to your spine, or it can be to your skeleton, okay? I've had people for years who would tell me, you know, I didn't have a Tarlov cyst, or I didn't have fibromyalgia, I didn't have any pain, but my auto accident was last year and my pain now started this year, okay? So any severe trauma becomes a risk factor, not the day you had the accident necessarily, but maybe a year or 2 years later, okay? Third risk factor, strokes, okay? People who get strokes do something that's terrible, and that is they bleed. Maybe it's an aneurysm, maybe it's a clot. There's any number of causes of strokes. Any kind of brain cancer or brain tumors are also in the same category. It wipes out enough of the brain tissue that houses your shut down neurotransmitters and receptors. So stroke, and it's been well documented that you develop what I'm about to talk about in a minute after strokes. It may take a few months or so. Another one, autoimmune disease. Okay, now autoimmune disease, I want to make something very clear because the definitions of autoimmune disease need to be known to the lay public, and even to a lot of doctors are confused by this. A lot of things are being called autoimmune diseases that are not autoimmune diseases. An autoimmune disease is a disease that creates what we call an autoantibody. Okay, autoantibody. Now, there's about 100 autoimmune diseases. Believe it or not, there's about 100. Type 1 diabetes is one. Rheumatoid arthritis is one. Sjogren's syndrome is one. Ankylosing spondylitis is one. Multiple sclerosis is one. All these diseases have what's called an autoantibody. What is an autoantibody? That's a piece of globulin, a protein in your blood that wanders around causing inflammation in tissues. And that inflammation, of course, is followed by tissue destruction and pain. So autoimmune disease, there's about 100 of them out there, and the common ones you're familiar with: lupus, type 1 diabetes, multiple sclerosis. There's also one called mixed connective tissue disease that actually is more common than people think. And then the last risk factor are people who are born with anatomic spine deformities or abnormalities. These are things like scoliosis, severe spondylolithiasis. Maybe they've developed spinal stenosis. So some anatomic spinal abnormality puts you at risk for developing a generalized intractable pain, actually. Okay, now you've got these risk factors, okay? Now, what happens if you have one of these risk factors? What happens is you develop something. Now, grab onto your chairs. You're going to need to start calling this inflammatory multi-system disease. Okay? Inflammatory multi-system disease. Now, what does that mean? That means that you have some kind of inflammatory generator in your body causing pain in different systems, in different tissues, and in different organs. Okay? Now let me explain what that is. And if we don't go much further today and we talk about this alone, you're going to have to bank this. Now, what do I mean by multi-system inflammatory disease? It's a disease. It's not a syndrome. It's not a disorder. It's a disease. That means that you've got some inflammation, or an inflammation that's being caused by either a virus that's reactivated, usually Epstein-Barr, or one of the autoimmune diseases. And it's going to start causing inflammation, for example, on your muscles. We call that fibromyalgia. Maybe it's pain in your head. We call that migraine. But that's really inflammation in your brain. Maybe we call that pain in the wrist. That's known as carpal tunnel. Maybe it's in your bowel. We call that inflammatory bowel disease or irritable bowel. Maybe that's periodontitis, which means your teeth are going to start falling out. Maybe that means that your face is hurting. Maybe you've got what's called TMJ or trigeminal neuralgia. Maybe your feet are hurting. We might call that plantar fasciitis. Or your joints are hurting. We call that bursitis. In other words, there are about 10 known with names conditions that really are just symptoms or complications of the disease now known as multi-system inflammatory disease. Okay? And I want everybody out here now who's got arachnoiditis, who's got RSD, whatever you have, if you've got it, or intractable pain, I want you to think back. What risk factors did you have? And then do you have this multi-system inflammatory disease? And I'm going to assure you, you probably do. Think back. A lot of you can tell me that today you got your fibromyalgia. Sometimes you can tell the day your back started hurting when your disc degenerated. Okay? Now, one other thing I want to cover, and I'll come back to that next week. You've got your multi-system inflammatory disorder, but you also may have another disease, and that's going to have a name also, and that's going to be called spinal inflammatory disease. And spinal inflammatory disease means that you have got inflammation throughout multiple tissues in your spine. Everybody thinks in terms of just disc disease. It goes long beyond that. You not only have got inflammation in your disc, you've got it in your vertebra. So that's your back. You may have it in your arachnoid. You may have it in your dural layer. If it's in your arachnoid, one of the first things you might get is a Tarlov cyst, or you may start leaking spinal fluid. There's something called the ligamentum flavum that gets inflamed and thickens. Bottom line is, and here I'm going to move on because I want to talk about some peptides for a second. Today, we've had to change our terminology and our approach to intractable pain. You have two big causes. One is inflammatory multi-system disease, or you have spinal inflammatory disease. Okay? And when people tell me they don't have a diagnosis, it needs to start with one of those two. Okay? And that's what you're going to have to understand, that most of the things now people think they have are really part of a bigger disease. Okay? So you're going to have to think about all this now for a little bit. And as time goes on these podcasts and in the writings and things that certainly I and my associates are going to be doing, you're going to hear us now not going to talk much about fibromyalgia or slip disc or arachnoiditis. We're going to talk about inflammatory multi-system disease, or we're going to talk about spinal inflammatory disease. Okay? That's what's happening. And you're going to hear us now talk a lot about what do you do about it. Well, first off, you sure want to try to tackle this pathway before somebody ends up in bed and is paralyzed and their bladder doesn't work and they're on 4 opioids and can't get help and are desperate, because that means they've got too much tissue damage throughout the body. So for those people who are in that condition, we're not going to forget anybody. We want to get help, some palliative care help. But the thrust is we're going to have to try to treat these diseases at the earlier stages. So next week and what on, we're going to get a little more into the new research on Epstein-Barr virus and on autoimmunity diseases and tell you a little more what we can do about those. One of the things we're going to do about it right now is I want to address something about peptides. We've talked a lot about peptides on this program, and there are about 60 peptides on the commercial market. Okay, about 60 of them. 3 of them have emerged as being popular among people with intractable pain. One is KPV. We started talking about that here. That's a combination of 3 amino acids, proline, valine, and lysine. And we have one called AR290. That pretty well grows nerves, and that's becoming quite popular. But the big one that's really popular is one I want to talk about for a couple of minutes, because frankly, we're getting some really, I don't want to say rave reviews, but we're getting some very positive feedback on the BPC 157, particularly when it's combined with thymosin beta 500. Okay. Now, I want to talk about what that is, these two together. First off, what is thymosin? Well, thymosin is a peptide that's made in the thymus gland and maybe some other parts of the body, but it's also a hormone. So it's both a hormone and a peptide. It doesn't grow tissue so much, but BPC does. BPC grows tissue. Thymosin beta 500, I believe the major thing it does is activate T lymphocytes, which kills off viruses. Okay, when you take the two together, you got a good thing going. It's not going to help everybody, but you're going to regenerate some tissues. At the same time, you may be suppressing or controlling the Epstein-Barr virus or the cytomegalovirus virus or the herpes 6 viruses. And you're going to need to kind of think in terms of that going forward. Our studies are showing, like a lot of the other ones, that the Epstein-Barr virus we found out of 110 adhesive arachnoiditis patients that every one of them have inflammation being caused by Epstein-Barr virus. Every one. And it made sense because that's the bottom of the barrel, you might say. Other conditions may have other viruses or Lyme or something contributing to the inflammation. Okay, we're going to invite our guest on for just a minute, but I want to summarize it in one sentence. I know I'm covering a lot of information. I know I'm covering a lot of information that may not even go down well with a lot of people. Okay, but that's what research is showing. It's a change. It's a big change. And that is, you have these risk factors. Some you're born with, some you acquire. And those risk factors set up inflammation inside the body, either through latent viruses or through an autoimmune disease. And so various tissues start getting attacked, start degenerating. So it's really not appropriate to say you got fibromyalgia and TMJ. You've really got multi-system inflammatory disease. It's really not appropriate to say you've got slipped discs in my neck and in my lumbar spine, because when you look at that MRI, we find that you've got arachnoiditis, you've got Tarlov cysts, you got a hypertrophied ligamentum flavum, you got tethered cord, you got all kinds of inflammatory diseases. So intractable pain is heading down a path to where the two major causes are inflammatory spinal disease and multi-system inflammatory disease. So you're going to hear more about it. Okay, we're going to shift over here now to introduce our guest. She's a very special person who is dealing with a lot of these issues herself, but she's also an attorney and a politician. And so she's helping all of us as long as helping herself. Now, the first thing you have to know about her, don't hold it against her that she's got one of the most odd names in the city of Chicago. Okay. But she's a lovely young woman. And I'm going to let her tell you about herself. But Kat, can you come on? Are you?
Yeah. Hi, everybody.
I can.
Okay. All right. Well, let's start for a couple of minutes. You're an attorney,
Yes.
and you're out advocating for us. You're a proud person trying to beat up the Illinois legislature. It's not a pleasant task, but you've been doing a pretty good job of it. Where do you want to start? We're going to leave it kind of up to you. You want to tell people, I'd like to have you at least tell them, where were you born? Where were you grow up? What took you to law school? Tell us about your own life.
I was born in New York, upstate, not the big part, in Ithaca, because my dad was teaching at Cornell at the time. He's a chemical engineer. I grew up partly in Chicago and partly in Dallas, so I'm a little bit of a hybrid there. I have EDS and CRPS and adhesive arachnoiditis, and I first started having symptoms when I was a child. They were in my cervical spine, and my shoulder would hurt really bad, but it was pretty intermittent at the time.
When you said you were a child, how old were you, do you think? Do you recall?
It was about 8, between 8 and 10, yeah.
Did they just say you had growing pains, or you were psychologic? What did they say your trouble was?
They actually thought that maybe it was the weight of my backpack and I should try switching shoulders. And since it wasn't constant, it wasn't such a big deal.
Mm-hmm. So what's your message to mothers and fathers who have an 8-year-old with pain?
Get them screened for EDS.
Yeah, screen for EDS. There you go. That's what I wanted to hear. Well, you'll get your paycheck later. Okay, you grew up with that pain. What happened next to you personally? When was your next episodes of pain, or what happened to you between the ages of 8 and 21?
So I was pretty active in that period, but when I got to law school, I was about 21, 22. And I, at that point, had just relentless pain in my hands. I had a really hard time typing, writing. I was able to hang in there with these compression gloves. They were neon green at the time, so they were terribly unappealing. And everybody would come up to me and say, "Why do you got those green things on your hand?"
So did you have any more episodes of pain anywhere between 8 and 21? I didn't quite catch that.
I did. My spine pain started to get worse and more consistent. The marker I can use is that by the time I started law school, that's when I knew that I had daily pain that, it wasn't really going anywhere.
But when were you diagnosed with EDS?
I was not diagnosed until 2022.
2022. And how did the diagnosis come about?
Actually, I had been talking to Dr. Klein since about 2017, and he was on a Zoom with me, and he said, "Has anyone ever told you you might have Ehlers-Danlos syndrome?" And I said, "I'm not even sure what that is," right? Because it was new to me. And he said, "Can you put your hands on the ground and stand without bending your knees?" And I said, "Oh yeah, and I could do this thing too, where you bend your thumb back." And he suggested talking to my doctors and taking the Biden test for hypermobility.
Right. Uh-huh. And
So
then you,
yes, I believe there are 9. Is it 9 on the Biden test?
yes, 9 points, yes.
Right. I think I was a 9.
You think you were a 9, okay.
Yeah.
Incidentally, you look like you have Ehlers-Danlos syndrome. Now,
I've
I'm
been
the
told
only,
that since
the only people who would know that is a few people like me who study it. And incidentally, that's actually a good thing because you're all, you have nice skin. That's one thing. And also, people with Ehlers-Danlos, I don't know how it happens. You're all really quite nice people. Okay, very cheery. And sometimes I think you ought to be a lot more depressed than you are. But anyway, whatever it is, we'll take you as you are. Don't change that part at any rate. Also, did you have any time before you were age 25, did you have any bad accidents or infections?
I did. I had a really bad car accident, a hit and run. When I was on the highway, somebody just slammed into me and drove away when I was about 17, between 17 and 19. I don't remember my exact age, but it would have been right around there.
And infections, what about infections?
I had chickenpox. I think I talked to you about that because you mentioned Epstein-Barr in the context of that.
Did you have infectious mononucleosis?
I did have mono, yes, when I was in high school. So that would have been around 16 years old.
Yeah. Let me just stop right here for just a minute. It's an amazing discovery, and I'm not just talking about my discoveries, but I'm putting together a compendium here of a lot of people's research. No one 2 years ago, 5 years ago, would have thought anything about your case. Your EDS, nobody, EDS is nothing. You can do somersaults and be on the cheerleading team. Nobody would have ever thought that car accident was going to affect you at age 40. No one would have thought that infectious mono in high school and your chickenpox was going to affect you as we sit here. Okay? Because what we now know, and we now know what happens. The body carries about 200 parasites, and the big daddy of all of them is the Epstein-Barr virus. And we all get the Epstein-Barr virus either when we're a child or when we get mono in teenage years or young adult years. And so you acquired the virus and at very young. And what we don't know is that and like that auto accident, the auto accident will activate a virus. And the virus is very, very slippery. What it does, it starts causing inflammation very slowly. And that's where that multi-system inflammatory disease comes in. And people with EDS are thought to have a depressed immune system. And I cannot identify any autoantibodies in EDS people. What I can identify is that you're kind of sitting ducks for Lyme disease, infectious mono, or other infections. And that auto accident is affecting you to this day. I make these points. I hope somebody's out there that hears this, or got a child, or a student, somebody they're in contact with who's got one of these risk factors, and if they've had that auto accident, they've had a severe infection like mono or like Lyme or pneumonia, they are at increased risk to developing multi-system inflammatory disease, and later on AA and all the problems that we're familiar with. Anyway, let me go on here right now. You've made it to age 40, right? You're 40. You're age 40. Now, up until we had some of these new tools, people with your condition didn't live much past about age 42. Elvis Presley had what you had. He made it to age 42, his mother to 48. And if you go back in what literature is available, and there isn't a lot, but very few people with EDS lived past about age 40. Now you're taking pretty good care of yourself. You're getting some help, and now you're out trying to help other people. God love you. So we appreciate that. I'd like to go two other avenues here. Well, one is, what have you done to stay as healthy as you can, stay functional, keep going? What's been your treatment?
My secret weapon is research, because I think that knowledge is power. So I've read a lot to try to educate myself about my condition, and so that I could also talk to my doctors about it. When I first met my current pain doctor, he wanted to do a device implant. And I asked him, how would that work with my EDS? And he said, I'm sorry, I don't really know what that has to do with anything. And I had to kind of direct the conversation from there.
Okay. And did you have a device implanted?
No. No, after I talked to him about the issues with potential, organ rupture, suture rupture, herniations, etc. No.
Yeah, I think you were smart. Okay. What else have you done, medically, therapeutically to stay alive and have a life?
I know this probably sounds like a little bit of a cliche, but I think being positive and active are really important things, not just physically, but on an emotional level, and building community. So that's part of why I do the activism piece of work that I do. And I also like to try to pay it forward, because so many people have helped me that I want to help people who are maybe in the same boat or something similar. But I did actually make a list of some things that help me, if they might help other people as well.
But don't hold back. That's what we're here to do now.
Okay, well, okay, so it's right here.
Now we're talking. Let's get down to that list here.
So one of the things that actually one of our board members, who's our pharmacist consultant, Steve Arians, recommended that actually helps me quite a lot, is to combine lidocaine with just take like a cotton ball and then put DMSO, which will then penetrate the epidermis. I said that right, Jamie, right? I said epidermis. So that's why I'm asking, because I said epidural earlier. It's not what I meant. And that actually helps. It gives you more relief over an extended period. I don't recommend it for really sensitive areas. So it works great for knees, things like that, but maybe not the most tender spots. I also am a big fan of the Stop Pain roll-on. It's just menthol, but it's really handy, and it doesn't make a mess, and it's, there's no spill, there's no cream or anything. All of these things are, you can buy them on Amazon or at Walmart or whatever. I do also, like I said, I think knowledge is power. So I have read your books. I have read Dr.
No wonder you're alive and well. Yeah.
Well, there you are. We follow the arachnoiditis protocols. We do the methylprednisolone once to twice a week. We do magnesium, we do a multivitamin, we do calcium citrate, we do B12, we do D3, those types of things. Soaking baths with Epsom salt and lavender help a lot. Things like compression socks and gloves help because I have dysautonomia, so that helps a little bit, especially with my feet, which get really cold. I also, like I said, I think this book is invaluable. If you have EDS disjointed, which I got from your recent book, but EDS arachnoiditis connection, you referenced it. So I read it, and you can see that I devoured it because there's these little notes here. But I showed this to my doctor, and he actually started reading it in the middle of our appointment, and he wouldn't put it down. So
keep trying. We're the doctors are coming around slow. Okay, let me switch gears a little bit. And you have attempted to take Illinois and get some intractable pain legislation passed, and you've had some good luck up till now. I'd like to hear how you decided to do it, what your legislation is, and give us a rundown on the success you've had. I think you've made a difference.
thank you. I hope so. We're trying. So I decided 3 years ago that I felt that I should be talking to my elected officials and trying to make a difference for more people. Once I felt that I was at a more stable place in terms of my medication and pain management, et cetera, which culminated in House Bill 5373. We had a House Human Services Committee hearing in March, which I testified at and was asked some questions at, and it was passed unanimously, 9-0. Then it went to the House floor, where it passed again unanimously, 105-0. We are awaiting Senate passage, but we have the backing of the Illinois State Medical Society, and their chief lobbyist and vice president will be meeting with our state Senate president in a couple of weeks, one-on-one, to push this bill through.
Now, what does the bill say? Fundamentally, you don't have to read it, but can you give us a general idea? What does it say and what does it do?
One of the core things we decided upon was that there should be no morphine milligram equivalent guidelines instituted or utilized. So that's one of the pieces that we felt was really important. Another piece was to require a court order or a court subpoena in order for law enforcement to access our prescription monitoring program. Here we call it a PMP. Don't ask me why. I know everyone else calls it a PDMP, but that's a piece of it. We also just put into writing that the treatment decision should be made by the doctor and should be, basically protecting and respecting the doctor-patient relationship. So those are some of the things that we did. Those are the core things that are in the bill.
Very good. When does the Senate vote come up, do you know, for hearings?
Well, actually, depending upon what happens in the next couple of weeks, we may very well have a law. But I will be keeping you posted.
Yeah, good. I know you will. Well, thank you so much. I hope we have Mark, my associate here, Mark Ibsen. Mark, where are you, Mark? Or Rhonda? I'm
right here.
Oh, great. Okay. Legislation's right down your alley, Mark.
Wow. Yeah. I want to acknowledge Kat. Thank you. It's good to meet you in person, or as close to in person as we get. Thank you for all you're doing for us. Dr. Tennant, you asked me to do some research on the article in Pain News Network from Dr. LeBaron, who's a kind of a whistleblower from the CDC. I've looked at a couple paragraphs of that. I have to tell you, I've been busy responding to calls from my attorney, and and so I'm sort of up to my eyeballs in medical board actions against me, and a new development in my case in Oregon, and I'd like to speak about that just briefly. So I have a patient in Oregon who's ultra rapid metabolizer, Ehlers-Danlos, complicated, constant pain, and about 3 months ago, the Board of Medicine investigator contacted her and freaked her out when he did. And I have this paternalistic attitude towards some of my patients. It's like, don't mess with my patients. It's sort of like, don't mess with my children. And I responded to this investigation by inquiring, are they investigating me? And why would they call my patient when I have the information that they would want if they wanted it? And they didn't talk to me. And then I sent them several emails. And then they said, stop sending me emails. Stop sending emails because we're not investigating you. So that was 3 months ago. 3 days ago, a law enforcement detective called them and called and left a message at my office. Again, my patient was freaked out by this interaction. I did not get the message from my office. And then when I did, I asked my attorney and he said not to call them. So the next step in the escalation was they sent the detective and a mental health worker to the home. And they let the mental health worker in. It was a welfare check. I have no idea who instituted this welfare check, but the patient tells me that the Board of Medicine instituted a welfare check on the patient. I have not sorted out what exactly is going on, but law enforcement is involved and provoked by the Board of Medicine. And I'm quite upset about it and can't really think about anything else. So sorry I haven't done my homework. The dog ate my homework. But what concerns me about this is it's one thing to have a Board of Medicine action. It's another thing to have law enforcement involved. And when law enforcement's involved, things are going down a completely different pathway. So say a prayer, please. That's all I got.
And Kat, like you respond to this, and Mark, what you're doing fundamentally, you've got some states that don't want to treat these people, but then they don't want anybody outside the state to help them either. In other words, what I'm hearing is you've got this state of Oregon saying we don't want this person to get any help or welfare and just assume they die. I mean, what other message are we supposed to get out of this?
I can't think of another one other than some sort of hostage situation. But in doing some research about this case, I came across the CDC opioid rapid response team that they allege exists. And I was looking up for a couple of patients who wanted to know if there's anything else anybody could do. And the CDC opioid rapid response team has an email, no phone number, and they've never treated a single patient. So I'm the CDC opioid response team right now. And I intend to use this as a defense that given that the CDC has an opioid rapid response team and no one implementing it, I consider that to be my cause that, okay, you're not doing it, I'm doing it. And hopefully that'll be a defense for me. I don't know. More will be revealed. I'll keep you guys all posted about this, but this seems like a fairly aggressive turn. And I think I've pissed some people off, which I knew I was doing when I re-entered the opioid treatment field. And so now it seems to be like a little bit of momentum going in from Maine and from Oregon. So I'm bi-coastal now.
Well, I salute you, and I'm so happy you're trying to help until maybe we can figure a way out of that. Rhonda, I see you're back on the air. Rhonda,
Yes.
do you have anything you'd like to ask Kat or Dr. Ibsen, or comments you'd like to make?
Well, both of you are just Dr. Ibsen. Of course, we're going to pray for you. keep that situation. That's scary. Definitely keep you in my prayers. Kat, wow, I just got to say thank you, man. This is really good. I always have trouble saying that word. It's a really good bill that you're working on with the no MME required court order for law to access pain scripts, and then that the treatment decision should be by the doctor. I mean, I don't know how we've got so far off track here, but here we are, and here's you, like, you're in there doing something about it. And I just want to tell you thank you on behalf of all of us. Every single one of us appreciate you.
Thank you. I
Yeah.
couldn't do it without this community. And I did send you a message, Dr. Ibsen, to reach out to me if I can help you in any way.
That's
Thank you.
good.
You ask a good question. How did we get in this mess? I look back and there was a time when law enforcement got me into this business. There was a time when the Department of Justice knew the difference between an addict and a pain patient. They wanted both helped. It was a different world. And then something's changed out there. I mean, I'm old enough to have come up out of the times in which we not only thought it was a right to get pain treatment, it was the best thing for the health system. We could keep people out of the hospital. We could keep their costs down. We could put their families together. In other words, everybody won. And then something went terribly wrong. I don't quite know what it was or when it occurred. But remember, we had the fifth vital sign, scales of 1 to 10, and it's like the curtain came down at some point. And I truly don't know what happened in the country or who was behind it. I think it's just important to know that there was a time we would not have this discussion, okay?
Right.
And when good people wanted other people taken care of, okay? So I know it's possible, okay? And I don't want to hear that opioids and these medicines cost a lot of money. Do you realize what it costs to put a stimulator in somebody today? Or
Yeah.
$75,000.
No, that's half. It's now 150. Half was just for the device. The other half is for the hospital. Mark, you're a great doctor, but you're poor on economics.
No shit.
Well, we've had a great session. Thank you, Kat. Thank Rhonda. Dr. Ibsen, hang in there. As you know, you're with us, and we're going to generate a lot of prayers. And if there's anything else anybody can think to do, please do. It is important to look at this new book that's out. There is a whistleblower who was inside CDC when they drafted the guidelines. And Kat, I would think every legislator in Illinois ought to have a copy of that. It really points out that the CDC guidelines, which has made all this worse, problems came about before it, the guidelines, but that shows you I believe his title or subtitle, it was greed to good went out the window or something like that. At any rate, we'll sign off until next week. Thanks everybody, and let's carry on. We'll see you next week. Bye-bye.
Thank you,
Thank
Dr. Tennant. Thank you, Dr. Ibsen. Thank you, Kat.
Thank you, Dr. Ibsen.
Rhonda.
Thank
Thank
you.
you, Donna, and everyone who showed up.
You.
We appreciate
God bless.
all of you. You are not alone.
Appreciate
We'll
you.
see you again next week. Please do, those of you who pray, please keep us all in your prayers, especially Dr. Ibsen and his situation. And those that will, if we'll go to God in prayer before we go, in the name of Jesus, Lord, we ask you, Father God, to just open up the windows of heaven and pour out blessings that he cannot contain, in good measure, pressed down, shaken together, and running over. Lord, when hell comes against us like a flood, you raise up a standard against it. And we know that no weapon that's formed against us shall prosper. We know that every tongue that rises against us in judgment will be condemned, for this is the heritage of the servants of the Lord. And we know that you are the head and not the tail. Thank you, Lord, that you are the vine and we are the branches. Thank you that you make sure that your children are taken care of. You constantly look over us and protect us. We ask for special blessings over Dr. Ibsen, that you continually protect him and make all things turn for the good. Thank you, Lord. Amen.
Hi, Miriam.
Amen. Amen.
Wow.
Amen.
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 Now that's a
Amen.
prayer.
Thank you, Jamie.
I love
Thank
you
you,
all.
Jamie. Thank you, everybody.
Thank you too.
That's all y'all.
Love you. God bless you.
You're in my
Bless
prayers,
you.
Dr. Gibson.
You're in my prayers.
Yeah.
Well, thank you so much, Dr. Tennant and Dr.
Yeah.
Jamie. Thank you. Thank you all.
Thank you all too.
Thank
Thank you all too. You're not alone. We'll see you next week.
You're
Take
not
care.
either.
Thank
Love
you.
you guys.
Love you guys. Good night.
Love you guys.
Night.
Good night.